that care, if that patient is inpatient, something like that, that's where the nurse-to-nurse communication, needs to happen. If I know that they're going to have a lumbar spine treatment, I'm typically going to want to prepare that nurse that's going to be receiving that patient after they come to my clinic that, you might need to give them some Zofran, or something like that, some antiemetic within an hour or two after they get back to the floor, just in preparation for that.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with John Hollman, Senior Nurse Manager of Radiation Oncology at AdventHealth Cancer Institute in Orlando, Florida, about radiation therapy for emergent interventions. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, John.
Thank you for having me. It's an honor.
So to start things off, can you briefly explain which oncologic emergencies might use radiation therapy as a treatment modality?
First, I kind of want to throw out there that, there are official oncologic emergencies that we're going to talk about today, like the spinal cord compression and superior vena cava syndrome. But what a lot of people don't understand is that we also have, I like to call them emergencies, which can be anything from, super symptomatic, brain mets, bleeding, bronchial obstruction, etc. So they can be used for a wide variety, but the most common that we see definitely are the spinal cord compressions and the SVC syndrome.
Thanks so much. I think that's an important distinction that you brought up of some are true emergencies, kind of how we've defined them in our literature and our textbooks, but there's this urgent area where it's not standard treatment, it's not emergent, but it's something that needs to be done quickly for the same reason. So I think that's really important to include that definition in our viewpoint as well. So let's talk about the types of emergencies. When are these types of oncologic emergencies typically identified or diagnosed? When thinking about the entire cancer care continuum, when do patients typically present with these types of emergencies?
Well, like all emergencies, they're unpredictable. In my career of almost 20 years, I have seen them at the very beginning. And sometimes, unfortunately, that can be the patient's first sign or symptom that they have cancer. Can be something like, they've lost, the ability to walk, or the breathing gets difficult, like with SVC syndrome. I've also seen it, during the middle of their care continuum where, we finished, a round of radiation and then develop metastatic disease. And so the next time you see them for radiation can be for a cord compression, And then I've also seen it, obviously towards the end of their care continuum where this is a strictly, quality of life measure, palliation towards the end of their journey.
Sure. That makes sense. That kind of what, like you said, what makes them emergent and urgent is they sometimes just happen without any sort of prediction. Maybe just taking a step back a little bit, I think many oncology nurses are probably familiar with the role of radiation therapy as a kind of a component of the treatment plan. But how is the treatment, when radiation is used for treatment of these emergent or urgent conditions, how is that different? Maybe from your perspective or the patient's perspective, how does that look different compared to planned kind of cancer-directed therapy?
Very good question. Basically, this is what makes it an emergency. So in a typical radiation setting where it's not emergent, the patients will come, they're scheduled obviously for a consult. They meet the nurse, they meet the radiation oncologist, they come up with a game plan. You do a lot of patient education up front. They may come back a couple of days later for that initial simulation, which starts the treatment planning process. And then the patient goes home while the dosimetrist, physicists, and all that come up with the treatment plan, which can sometimes take 5 to 7 business days. Put that all aside in an oncologic emergency case in radiation where, sometimes it's, the patients are inpatient. They go to the ER with presenting symptoms of, pain, can't walk or something different. And, they get worked up in the hospital. They're calling the radiation oncology department to, either bring them over urgently by ambulance if you're an outpatient facility. And then that whole process that I told you takes sometimes 5 to 7 business days all happens within the span of a few hours. So as you can imagine, from a patient perspective and a nursing perspective, everything is pretty much rushed. That patient can be severely overwhelmed with information overload. If this is their first, presenting sign of the cancer diagnosis, and all of that treatment planning and stuff takes place while that patient is typically waiting, typically on a stretcher, in your clinic. And so there's none of that relaxing going home. It's all done because we want to get on top of that pretty urgently. So that's the major big difference. In our field, we call it an urgent simulation and treat, which basically means they sim and treat on the same exact day. So that patient can be there anyway in your department for sometimes, just depending on the complexity of the treatment plan, anywhere from 2 to 4 hours, before they receive that first treatment.
Wow. And it just makes me think, back to, as we talked about, kind of when do these emergencies pop up? Commonly, they can be sort of at the time of diagnosis, or what creates the diagnosis, essentially. And so thinking about those patients, they aren't even connected yet to who their kind of medical oncology care team will be, or, maybe the first oncologist they're meeting is the radiation oncologist and the team that helps support that treatment. And so it's just kind of putting my mind into that space for the patient. That's got to be even more overwhelming than just the cancer diagnosis itself, but then being rushed to treatment emergently because of the severity of the issue at hand. I think that just is important. I think for us as nurses to keep the patient's kind of state of mind, and their family, of course, just what that feels like. If that's your first introduction to their cancer diagnosis and the treatment, helping them to kind of process that, especially, once they get through that emergent treatment, of when they do hopefully get to a more routine approach of like, here's your diagnosis, let's talk about your treatment plan, when it doesn't have to feel so urgent. I think it's important just to kind of help your patient take a deep breath because I think that's an especially difficult way to enter into your diagnosis and treatment planning when there is that sense of urgency, but deservedly so. I mean, we can't do it any other way if there is something as serious as spinal cord compression, SVC syndrome, things like that. So in terms of the treatment planning, you mentioned kind of simulation and planning for the emergent radiation treatment. What types of diagnostic studies are typically used, or what helps to identify the oncologic emergency? And are those then also used to plan for treatment, or are additional studies needed?
So typically, let's take spinal cord compression, for instance. Patient journey usually presents with, extreme pain or localized pain, and they go, say, to the ER. Gold standard, typically for anything in the spinal column would be an MRI, and hopefully that patient doesn't have anything that, doesn't allow them to have an MRI, like a pacemaker that's not MRI compatible, something like that. But typically I know our dosimetrists and stuff really like, and our doctors like an MRI because it really kind of shows beautiful imaging. Is that tumor really encroaching on the spinal cord, or is it, just, getting into the bone right now? If they can't do that, obviously we'd have to use, conventional CT scan, which is not ideal, but it can still be useful, obviously, for targeting that treatment. One of the barriers possibly with that would be if, like where I was from in Texas, where we were strictly outpatient, not connected to any hospitals, a lot of their imaging would need to be burned on a disc and brought over. Patient could still be brought over urgently while they're on the sim table. The nurses are usually calling, the radiology department. Can we have that imaging burnt on a disc for treatment planning? And then hopefully you're close to the hospital. You could run over to the hospital and pick up that imaging, bring it to dosimetry, and they would upload it to fuse with the treatment simulation for optimal treatment planning. So that could be a barrier just depending on where you're at. But typically, like I said, for the spinal cord, you really want MRI as a gold standard. SVC syndrome, typically a CT of the chest. Even I've seen it sometimes diagnosed on an X-ray. Something as simple as an X-ray. If their patients are short of breath, they'll show that large, right-sided chest mass, and like we talked about, that can sometimes be their first, symptom that they have a really bad lung cancer or something in the mediastinum.
Your comments about, maybe having imaging, but then having to get it to the right place, it really puts the whole issue of EHR interoperability and cloud-based systems and things. It kind of puts that whole debate in a new light when you're talking about these types of emergent situations where it's not just nice to be able to see those same images. It's like, it's critically important that we be able to get the images on the right machines, again, for planning and things like that. So there's an interesting twist to that.
And I think this is why I'm glad we do these kind of podcasts, because, I've been in radiation my whole career, and I can't tell you how many medical oncology nurses or infusion nurses don't really understand what kind of goes on in our world. You really have to work in it, even on, I will say this, even on the patients that are scheduled, that aren't emergent, there's still a lot of stuff that we have to wait on. Did they get a PET scan? If you're not hooked up, like you said, with the cloud or any kind of electronic, imaging that can just come over straight to your planning system, sometimes you're waiting, or they say they had, a PET scan a week ago, but it's at a place out of town, then you have to worry about, the old fashioned snail mail, or overnighting, things like that. So it can add a little bit more stress sometimes in the oncologic emergency setting because, you really kind of want that disc for planning. Have I seen it when they're just using the CT sim? Absolutely, because it's all for palliation, and then we might change the treatment plan after we get those first couple treatments under belt and make it a little more focused, but it's definitely not a stopper, but it's definitely, like I said, that you want it to be the gold standard.
You think of if, I think in rural areas or in even community-based settings, I think many of us who currently work or have had previous associations with larger academic health centers or just large kind of health systems that are all connected throughout their region or their state even, great benefits to that. But that's not everyone's reality. And so thinking through what seems like just a relatively kind of minor coordination issue can be a huge burden and a huge barrier to getting timely treatment. And then where does that barrier land? Do we have a navigator or a nurse coordinator or somebody who can help kind of make sure all of those things are lined up and getting done at the right time? Or does the burden fall to the patient? Oh, hey, can you go down to the basement, take a right, stop at the desk, get your disc, and, call? I think those things are still occurring. And so those are important. Again, they seem in the grand scheme might be minor little things, but can have a huge impact. So just trying to think through how we help connect those dots and try to reduce the amount of burden that the patients have to shoulder so that they can just focus on themselves, their family and care team, and showing up and being ready for whatever comes next.
Yes.
So let's talk a little bit about the side effects of this treatment. So when we're talking about radiation given for oncologic emergencies, what sort of side effects do you typically see? I mean, is the course of treatment, how does that differ? And then are the side effects kind of different because of that course? Can you just talk a little bit about how this looks compared to maybe your standard radiation treatment?
Oh, of course. Yeah. Typically, these are well managed, because it's a shorter course of treatment. These emergencies aren't going to be coming into your clinic for 6 to 8 weeks. As you know, radiation is a site-specific treatment. So say they get a cord compression, their side effects are going to really depend on obviously where in the spinal column that we are treating, So say a patient has a cord compression at C5, obviously you look at the esophagus being an issue. If we do a 10-course treatment, which typically it can be up to 10 treatments, those patients typically won't get esophagitis or something like that until they're done, and it's nowhere near the severity of like a head and neck cancer or esophagitis, that's way different, but it can linger for a couple of weeks after they're finished, which if you don't prepare the patient for that, that can be alarming, and then take it down the other way. I've seen severe nausea, vomiting after one treatment if we treat a large, lumbar spine cord compression, because unfortunately, the stomach, stuff like that can get dosage. And this is where it comes into coordinating that care. If that patient is inpatient, something like that, that's where the nurse to nurse communication, needs to happen. If I know that they're going to have a lumbar spine treatment, I'm typically going to want to prepare that nurse that's going to be receiving that patient after they come to my clinic that, you might need to give them some Zofran, or something like that, some antiemetic within an hour or two after they get back to the floor, just in preparation for that. But other than that, side effects, like I said, because it's such a shorter course of treatment, are nothing like you would see during the traditional courses of 6 to 8 weeks. It's pretty well managed. Obviously, one of the good side effects can be pain relief. If we're treating for a spinal cord compression, they can have pain relief. I wish it was instantaneous, but it's not always. They can have some pain relief during the course, but usually it happens. They get some pain relief after we're done with them.
When we're giving radiation for an emergent situation or maybe highly urgent situation, is it a true statement that the strength of the radiation that we're giving is not as strong as typically a full course of treatment like cancer-directed therapy, and or is it always typically shorter as well, a shorter duration of treatment?
Yes. So we have in our field what we call hypofractionation, which, go to your medical terminology, hypo meaning less, which basically what happens is you increase the dose per day, but you're doing it for less fractionation. And fractionation is a fancy term for what we call a treatment number or the treatments delivered. So for instance, sometimes with a cord compression or something like a bronchial obstruction, we will give what's known as the palliative 8 gray times 1, which is a super large dose for immediate palliation. So to answer your question, it is a larger dose per day typically than you would for 6 weeks. So you want to give a lower dose per day if you're going to stretch it out for 6 to 8 weeks. Shorter courses like these for emergencies are a higher dose per day, but a shorter time frame of treatment, if that makes sense. Did I explain that correct?
Yeah.
So if they get 10 treatments, you're going to give a larger dose per day to get the total dose to be something that we know can help that disease, but you're doing it in a shorter time frame.
Gotcha. And that makes sense, right? Because we're looking at whatever, if let's say it's a spinal cord compression, we're looking at that lesion that's compressing the spinal cord. We want to, as quickly as possible, shrink that. And so using a big dose, but not as often or not as long, maybe, to try to just, again, relieve that immediate emergent concern of completely compressing and causing paralysis and those types of things. The intent of the treatment in this emergent situation is kind of short-term palliation so that we can eliminate risk of kind of long-term or permanent issues, to then give us that time to then take a step back and do the long-term look at, like, what is the long-term treatment plan? What are we doing systemically? What can we, does radiation come back in sometimes? I mean, I'm sure that depending on what their kind of primary diagnosis is, that might be part of their long-term treatment plan. But in this setting, it's just like quick and heavy, and let's fix this emergent problem right now so that we can then get to that point where we can kind of more methodically do the larger long-range treatment plan.
Absolutely correct.
Then back to side effects like we talked about, are there any specific assessments that you think oncology nurses should use to recognize the side effects specific to what they should expect or they might see related to oncologic emergent radiation treatment?
As a nurse, I kind of like to overeducate. And as a nurse, you can tell which patients are more receptive to knowing everything, and some don't want to know the bare minimum. So over the years, you develop that as you can kind of tell. But also that involves a lot of the family that's with the patient too, just to prepare them for everything. Sometimes tumors don't like radiation, so sometimes you can have a pain flare. So I always like to prepare, patients for that. And that can be for anything bony that we're treating. They come to us for severe pain, so sometimes I like to prepare them like, hey, this treatment within the first couple fractions or treatments can cause, massive inflammation, which we call it the pain flare, which will subside. But I like to prepare them for that because sometimes they'll think, oh gosh, this isn't working, or
you're making it worse.
You hit the wrong area. There's so many misconceptions, like, is this supposed to help me? Not, whatever. And like I said, especially in the setting of core compression, typically if it's pretty symptomatic, hopefully they're on a high dose of steroid, either PO at home or in the hospital, which can help with that inflammatory response with that. But other than the education, like I said, because the thing that's different with these patients is sometimes those side effects will hit when they're no longer in your clinic, So I like to prepare them, hey, I know you've done your 10 treatments. You might have a scratchy throat that can get worse for the next 1 to 2 weeks. That's normal. Usually we'll send in something, where the hospital can give them, some magic mouthwash or something to help them get through that. But, typically any side effects that appear will linger for a couple of weeks after treatment, just like the normal side effects do.
Kind of related to that and sort of leading into the next question, let's give a scenario where a patient maybe was in the ER and was found at the ER that they have this lesion that needs to be treated with emergent radiation. Once that course of emergent treatment is done, in your experience or in your practice, do you see that patient back in the clinic for like a follow-up, or once they are handed off to medical oncology or surgical or whatever comes next for them, is that sort of assumed that they will take over the care from there? Is there a follow-up to the emergent setting, or is it kind of handed off?
I wish I had a black and white answer. Honestly, it's going to depend. I've seen, doing this for so long and working in such a variety of practices and working with some amazing different radiation oncologists. Let's just say, for instance, let's take the scenario that this is their first presenting symptom. Let's just say core compression, right? The patient didn't even know they had lung cancer, but their first sign was worsening back pain. They go to the ER. Oh no, I have a lung cancer now. They'll come to us, get the radiation for, core compression or SVC, get that done, and then go back to obviously the medical oncology. And this is where it really comes into coordinating that care, getting someone directed to the medical oncology office, making sure that that team knows, like, hey, we're going to do radiation for 10 fractions. I mean, obviously the med onc can see them anytime, in between, but making sure that they go for that follow-up care, putting them on probably some kind of systemic treatment. Have I seen it in both ways where, yes, the rad oncs want to keep up a follow-up with them? Absolutely. Have I seen it where we're going to do this, and if you need us in the future, the med onc will obviously refer you back to us in that scenario?
And that makes sense. I mean, and that is our next kind of topic to discuss, is the ways that radiation oncology and medical oncology can coordinate or work together to ensure that the patient not only gets the proper treatment, gets the right education at the right time in these scenarios. So I think that was a great example of kind of talking through that. And I think that I'm a medical oncology nurse by training. That's the lens I have. And I think we've already brought up some really important points of that. If a patient comes to me and they've already had emergent radiation therapy, kind of trying to put yourself in that patient's shoes to understand what do they know and not know yet about their diagnosis, not making assumptions, understanding what treatment they have received. And because they will hopefully either simultaneously or quickly in a sequential manner be referred to medical oncology to kind of continue that systemic discussion. But then if they're going to be in medical oncology's kind of realm at that point, we need to know what to expect in terms of side effects from that emergent course of radiation. So whether they get it before they come to us in an emergent setting or radiation becomes part of their treatment plan during or after medical oncology has their turn, it's just very important for all oncology nurses to understand, it's wonderful that we have all of these different subspecialties. And I think it's great that we have the opportunity to subspecialize and really feel like we understand a little slice of this giant pie, but you can't live and exist in that silo without understanding that your patient's going through all of those phases in a lot of cases.
And I like how you worded that, because it's just not the biggest frustration with MedOnc and RadOnc is those silos. And I don't think it's intentional to a lot of places. I think, some places it's geographical. You could have your standalone radiation and not have MedOnc, and they might be away 4 to 5 miles. You can have those great comprehensive. I've been in many comprehensive cancer centers where MedOnc was just upstairs. Does that mean we have the best of communication? Absolutely not.
No.
But what I like to stress every time I do lectures or talks is go to MedOnc, go to RadOnc if you have. I know we nurses, we don't have time, but there's always time for this. Go meet your MedOnc team. Go meet your MedOnc nurse. With me being the manager of such a large facility here, we do teams. We do a lot of teams because our MedOncs, we're on the first floor. MedOnc is on the 8th floor, So, and the likelihood that we're going to run into each other or you're going to answer your phone is, be honest, slim to none. So we have MedOnc teams. So we coordinate care through there with them and say, hey, Mr. So-and-so's finished his 10th fraction for his spinal cord compression. Just FYI, he's done today. You're able to take over. And sometimes they're like, oh gosh, thank you. I needed to get him in for a follow-up. And I think in a perfect world, every single person can do let's walk in your shoes. So I love it when MedOnc nurses want to know more about radiation because I walk them around the department. I have them watch treatments. I have them watch a simulation and they're just blown away. They're like, wow, I had no idea that so many people were involved in just formulating a treatment plan. So, I say, get to know your MedOnc, get to know your RadOncs, and this communication can be opened. It doesn't have to be a silo if you don't need it to be.
Absolutely. And I think as an example, I think we're all familiar with tumor boards or having that kind of conference where typically driven by the physicians or the advanced practice practitioners where they're talking about routinely prognostic cases. So here's their diagnosis, here's their treatment plan we recommend, kind of talking through future forward thinking. And I've seen great examples of how nurses can do that too, more in the coordination of care setting where we're bringing together the nurses, the navigators, the social workers, the dietitian, and having those same conversations, especially for patients that are being shared across disciplines, where we're saying, okay, Mr. So-and-so, he's with radiation. He's getting this treatment plan. He's going to finish approximately this date. So let's get him lined up for the next 3 cycles of his systemic treatment. So I think that tumor board kind of feel can be extremely helpful to help just eliminate as many of those fragmentations of care and help the patient. Again, we should always be one step ahead of what needs to come next and not be reacting. And that's hard to do because there's so many moving parts across departments, across floors, across state lines, depending on where you live. It's a critical, I think, step for nurses to understand that they can have those same meetings and those same structures and really help impact and benefit patient care.
Well, and to make it even more unique problem is a lot of radiation facilities and MedOnc are completely separate companies. I've had it both in Texas and where I am in Florida, where there's a large MedOnc group, which is separate. The EMRs don't talk, they don't do anything, but they only provide medical oncology. So obviously the radiation referrals have to come to us. That's the extra barrier that you have to break through. And, like I tell my nurses here, I don't care if they're outside of our facility or our company. We need to develop some kind of, is there an email address to that nurse? What is their backline? Something like that. Because coordinating care, especially with oncologic emergencies, stuff like that, if they come from an outside MedOnc, that can be problems, and it's up to that nurse to try to hopefully break down that wall beforehand. And, hopefully their MedOnc and RadOnc even have a text conversation or something that they can communicate as well.
Absolutely. Yeah. Creating those sort of inroads and pathways to, as a referring office, you shouldn't be stuck in the call tree, right? Like there should be a more direct way. And with technology and email and certain electronic health records, again, if they're not shared, you can't use that. But certainly, I think easier than it once was, relying, on fax machines and things. But that's so important, just figuring out, who is my point person at this office or in that department. They might not be the one to do it all, but I know that they can help me find the right person. And so creating those relationships is about building those relationships, with other departments and understanding that we're all doing the same thing for the support of the patient. So very important to keep in mind. Speaking of other departments, we've maybe touched on them a little bit, but what are some other departments that we typically see involved or at least looped in at some point when we're dealing with patients who are receiving radiation for oncologic emergencies or urgencies? Are there other referrals that are typically made or should be kept in mind?
So take it for instance here. So one of the reasons I love doing what I do is the patient education. So, sometimes the patients, like we said, this is a presenting symptom. They come to your department, they're with you for about 3 to 4 hours while they're waiting for their first treatment. That's where I really like to go over and actually talk to that patient, one-on-one. And, no offense to physicians out there, but these patients are so overwhelmed. As nurses, we're taught, we're patient advocates, they can hear one thing or not, it's selective hearing and they're so overwhelmed. And that's my time, to really sit down with them, try to explain exactly what the process is going to be, while the physician is busy with the dosimetrist planning that treatment. This is my time to step in and just say, hey, this is what's going on. Obviously, most of them can be really emotional. And that's where we have great chaplain, services or whatever their religious beliefs. Hopefully you have a system that has a chaplain or that can provide, some emotional support. We have amazing social workers here that this is their forte. They will come. It's not been a problem for me to go get my social worker and have her come over with me and talk to that patient, because this can be life-changing for them. Let's be honest, it is. Now they've got to think about, okay, now I'm a cancer patient. I was just fired from my job. And this is where social work really needs to get involved, and they can help setting up with resources. God forbid if that patient has young kids at home, just to kind of help them get all wrapped into it. And, we obviously palliative care, if you have a palliative care department, comes in and help. I think those are the two big ones that come on, just off the top of my head that we always get involved with.
And those are great. And I think that's just always important. We as nurses, I know that I always defaulted to I can fix this. I can do this. I'll just take it all on. But certainly that's becoming less and less possible, not only because of just the expertise that's required and how we are so lucky to have so many different clinical kind of specialties and support that can help the patient in very unique ways that those individuals and those practitioners are uniquely trained experts in. And so I'm glad to have teammates. And I think it's important for us to always remember who can we include in that patient's care so that they are getting at least introduced to as many services and resources that potentially can help them. And so I always love hearing that people have those members of their team. And not everyone does, unfortunately, depending on the size of your institution, it might limit what the resources are for you to even tap into. But whatever is available, always, keep them looped in and keep them in mind to make sure that that patient is just getting exposure and introduction to what's available to them. So back to more the technical side of the treatment. In addition to obviously the radiation treatment that's being administered, are there any medications that are given kind of alongside, before, after in the setting of the emergent radiation treatment delivery? And how can collaboration with medical oncology, how does that look to make sure that those medications are given timely?
This is a big thing for all radiation oncology nurses. Again, depending on your practice, where I came from a strictly an outpatient, we did have an outpatient pharmacy upstairs, but if that patient's coming from the hospital, I'm going to want to receive report from that nurse that's taking care of that patient. If it's on an oncology unit, most of them know about the stimulation process. They know that patient's pain level. I mean, to be honest, if that patient is screaming out in pain, laying on our hard treatment table, laying on our sim table for whatever positioning, sometimes if it's in the thoracic spine, the patients have to raise their arms above their head. If a patient has multiple bone lesions, it's just timing of a high dose of a steroid, timing of, some kind of IV pain medicine is ideal prior to them being brought over to your clinic, because you don't want that patient to be brought over to your clinic if you don't have the resources and they can't even stay still, on the table. Not a lot of clinics have just a pharmacy at their disposal that's in-house, So I think that's imperative to kind of work out with the facility that they're in, if they're inpatient or anything like that. But I think those are the primary ones, the timing of the pain medicine, and then getting those floor nurses kind of educated, hey, this patient's coming for radiation every day at 2:00. Can you please give them their IV morphine or whatever, scheduled, an hour before they're brought over, please? Because I can't tell you how many times, and believe me, we all know nurses on the floor get busy. God, all respect to them. Sometimes, it just gets missed or something like that. Those patients come over and then they're in your clinic. You have the therapist come over to you, Miss So-and-so, she can't do her treatment. They didn't give her pain meds. And you just hear her, on the table. Worst case scenario, if you have the means, go to the pharmacy, making sure, and then it becomes too complicated. Then you have to get into the hospital EMR system, make sure that they didn't give them pain meds. It's a whole big thing. So I think that proper communication up front is imperative. And I believe therapists can get involved with that as well. Sometimes some facilities, a therapist will be in charge of arranging transportation, and if they don't know to ask for that, please medicate the patient before you go. It's good to get the therapist educated, in that as well, because they're the ones that have to treat them safely. And if they can't stay still, that's a safety risk, definitely.
Absolutely. Well, I think we could have a whole other discussion just on the roles in radiation, because I know that just understanding the radiation therapists and their role and how they function as part of the treatment and actually administering the treatment and the scope of practice for them versus what a nurse can do, but how those two roles have to work together kind of side by side, because many days the radiation therapist sees the patient more than the nurse does, depending on, the flow through the clinic and who has their treatment visits that day. So, I just think that's such an important piece that I think many medical oncology nurses might just not fully understand or appreciate, just the nuance of how these very unique and specific roles in the radiation space. We don't necessarily have duplicates of those in medical oncology. And so it's just a different way to approach sort of a team-based approach to care.
And, and unfortunately, some radiation oncology clinics in the country don't employ nurses. They're just based on medical assistants and therapists. That's a whole nother. Yeah. And trust me, I know it makes me cringe. Not that, nothing against medical assistants. I was one for years, but, there's also that scope of practice that you have to deal with and triaging and stuff like that. And it's just, that's a different conversation. Like I said, since I've been radiation therapy for so long, I was going to go to school for being a radiation therapist. So I used to be in the room working with the patient setup. So I had that unique understanding of how important those radiation therapists are in the delivering of treatment.
We've touched on this a little bit, but maybe just to summarize, what are some of the best ways that oncology nurses can support patients who are receiving their radiation therapy in this emergent setting?
I'm a 100% proponent for education. The more educated the patient is, the less likely they're going to be, or lessens their nerves, basically. I feel like the more educated the patients are, they know what to expect. They know every step of the process. Sometimes patients, we kind of brush over that they're going to be going through a simulation. They're like, well, is this the treatment? No, that wasn't even the treatment. That's just getting you set up. Because a lot of patients, if you don't explain it, they're going to get a sim and be like, why am I not back in my room? I was like, oh, no, you haven't had treatment yet. You know what I mean? So it's just really being on top of that and what to expect. God forbid, too, if it's a cervical spine treatment and that patient is claustrophobic. I don't know if you've seen the treatment mask. Those things are intimidating. They're kind of locked to the table. And, if you don't prepare them for that, that can be very anxiety inducing for them, So I think it's just kind of, that nurse just kind of needs to know and prepare that patient for every step of the process. Even though technically they're not in there with the sim, I like my nurses that I have here to be understanding of what the sim and what the patient goes through, so they can better educate those patients. And they're, in telling the patient that the radiation is not going to hurt. It's just, it's like getting an x-ray every day, because they're thinking, you're going to start an IV, you're going to do all this other stuff. It's just kind of lowering those anxiety causing issues ahead of time so the patients are better prepared to what they're going to go through.
It's sort of like two ways to approach it. You have to either address all of the preconceived notions that the patient might be coming in to their sudden emergent situation with. As soon as they hear that, oh, this is cancer and, oh, we have to give you radiation, they probably have family or friends, or they've seen movies, or they have all of these expectations of what that means, whether they're based in reality or not. So weeding through that is important. But then also they might have none of that. And so understanding like how much do they need to know to get through this hour, this day, or this course of treatment. Because I think also we can quickly, because we love to teach and we have so much information to share, we can quickly swing too far the other direction and overwhelm them. And so it is this delicate balance of finding that kernel of truth and reality of what this experience really will be like for them, and giving them as much information and support as they need so that they can get through that treatment, as you said, with as little anxiety as possible and with confidence of understanding what's about to happen and what's going to come next.
And I've worked in places, I have a great team. I usually have places that have a great team. And even if I can't get a chance to prepare them for the SIM in greater detail, we have amazing radiation therapists that are educated they will take the time when they're in that sim room, preparing them for step-by-step, ways to go. And, like I said, it's just a matter of building so that your team can all be on that same page. I feel confident handing my patient off to that sim therapist. If there's issues that I know the patient has, I'm going to run over there and tell that sim therapist and be like, hey, Miss So-and-so's here. I know we're treating the cervical spine, but just know she also has a right arm fracture. So be very careful with that. Just a heads up is never not appreciated.
Well, and as we said, it's a team effort with all of the different roles, especially this day and age with nursing being staffing a huge issue across the board. We are having to be creative in terms of how we approach team-based care, and scope of practice cannot be ignored. It's very important to understand who has what role and delineating what their responsibilities and legal possibilities are. But at the same time, there are things that we all can share and participate in, maybe in a very unique way. And I think education is an important part of that. Nursing needs to own and drive that, but there are things that we can teach our colleagues and our teammates to say, here's what I've said to them, so you can help reinforce that. Here's what I know, and I've taught them already. So if they have questions about that, let me know so that I can provide some follow-up on that. So it is about communication with our teammates to make sure that patients are getting consistent, clear information, but also that they feel like they can reach out to anyone on the team and ask that question and know that they're going to get the right answer as a response. Well, John, this has been a great conversation. I feel like we could probably keep it going for another hour or so, off in various directions. But for the sake of today's time, we are wrapping up today's episode. So we like to ask a few quick fire questions just to summarize things. So to start that off, what are some common misconceptions about using radiation therapy for urgent interventions?
Like, I think of what you and I talked about, the worried about instantaneous side effects, worried about, they're going to go back to the unit or wherever they came from with, horrible, horrible side effects. And outside of the rare, nausea, vomiting, if they're doing a lumbar spine, that is definitely not the case with us. Side effects are cumulative. So I think that's a big misconception. I think a misconception also is that we can give the treatment and plan and do everything within like 20 minutes. Which is not the case. I think a lot of places think that, they're going to go over for radiation department and they're going to lay on the table, get their treatment, and then come back, now, albeit that's the case after we've done that first treatment, but not for that first, treatment. So there's a lot of, as we know, it could be hours, it could be, 2 to 4 hours sometimes, for that first treatment to take effect. So I think that is a misconception that, we can be treated in 20 minutes. But other than that, I think those are the two main ones that we like to dispel.
What's something about this topic that's not often discussed, but you wish people knew more about?
That's a hard question. I mean, just going back to what they are, we try to be as quick as possible in the safest way possible. Is that going to mean they're going to be down there for sometimes an hour or two? Yeah, it depends on multiple factors. Has this patient had radiation to that part of the body before or close to it? It's not just so cut and dry. And I think, I wish people would understand more about, there are people in the back. Dosimetry has a lot of planning that they work with the doctor on the fact, and it's not always just a cut and dry, shoot, and go back.
What additional training or education do oncology nurses need to understand radiation therapy in this type of intervention and also prepare for it in their clinical practice?
So listening to things like this, podcasts are very informative. Radiation and nursing education is very hard to come by. It's something I have staked my career on trying to fix. And things like this, I like my nurses to be educated to know the prevalence. So for instance, you get a right-sided lung cancer, those are more prone to developing an oncologic emergency like SVC syndrome. If it's a small cell lung cancer, aggressive type of lung cancer, those are going to be more prone to developing, SVC syndrome. So I want my nurses to know that so they can tailor their assessments to that so you can hopefully catch it earlier. Oncology Nursing 101, never ignore back pain. Never, ever shy away a back pain, and that is going to tailor their, like we said in the beginning, you got to get on top of these things early, Yeah, could it be a false alarm? Absolutely. But at least you're doing your due diligence to rule out the worst case possible, scenario that, okay, good. It's not a core compression. It's just normal aches and pains, but, at least you've ruled that out. It's just knowing, like I said, the prevalence, am I worried about back pain in a stage 0 breast? Not so much, but am I still going to assess it? Absolutely. Am I worried about SVC syndrome for that? Not typically, but, things like that they can tailor their education for to be kind of more aware of the early signs and symptoms of it. And I think topics like this, well, what are the early signs and symptoms of things like this that they need to be educated about is great. I love I'm not just saying this because this is ONS, but I love that radiation manual. It's been my go-to since I basically have been in my career. It can be a little daunting to look at, but it's a great way of kind of tailoring your nursing assessment, what's to look out for, and obviously the radiation therapy certification course, you do it at your own time. I took it about, maybe 10 years into my career, and I was like, wow, I learned something I hadn't, thought about before. I think resources like that ONS can provide, and even some outside, vendors, rtanswers.org is an amazing patient education source, but also I make all my new nurses kind of peruse those videos and watch that because, it's very easy to see, and there's videos that can show you to the simulation process. But just off the top of my head, I think those are the best ones, but great ways to understand all of that.
That's wonderful. And I think I'll add one that you already mentioned, which is just go meet the team that you work with. Go spend some time or just talk with the radiation team that maybe your practice is affiliated with or refers frequently to, and just, pick their brain, understand what their daily routine looks like. And I think so much can be gleaned just from understanding the process that underlies. As you said, a lot of the misconceptions are related to time and efficiency. And it's just because what happens once that referral is made is this sort of nebulous black hole of, I don't know, I just know that it gets done and then they come back to us. And so understanding how complex that process can be is just really important.
Yeah, I agree 100%. Each of us, your specialty, medical oncology, we have concurrent therapies, each of us is going to have our things that we're waiting on. You know what I mean? Insurance, number one, port placement for chemo, whatever. Ours is the treatment planning. Did they get the right scan? We might need another MRI before we start treatment, and then there's a treating process, which can take, 5 to 7 days. It's so many multiple factors of that. Each team needs to be aware of different things, you know what I mean? Of what we're waiting on the med-onc side, so we can start these together, or just in general, Agree. We'll break those silos down. We'll do it.
And finally, are there any additional resources for patients or providers who want to learn more?
Right. So like I said, I am an avid user of rtanswers.org, sponsored by Astro. It's a great education resource. There's bilingual videos on there. And, it's true. You can hand them pamphlets all day. Are they really going to read them? Yeah, some do, some don't. But to watch an actual video, a site-specific video of your treatment and what you're going to go through, I think is imperative. So like I said, all my new hires, some are new to Radon, I direct them there. I say, watch these videos. It can give you a good idea of what you're going to be dealing with here in the clinic. I think that's a great resource.
Well, John, thank you again for such a great discussion today. I really learned a lot, and I appreciate all the new topics we uncovered that we can continue maybe on a future episode. Do you have any final comments today?
I will say that I love that radiation is finally getting, we have the radiation track now at Congress. I'll be speaking at it next year. I put on the 2019 one in Anaheim. Like, this is what we've been asking. And surprisingly, like I said, the turnout from med-onc is great. Like, they want to know what we do. It is a specialty, even though we're not actively administering the treatments other than radiopharmaceuticals, but that's a separate talk. We are important. We are there to deal with these side effects, to manage that, to triage that. And I think that is, imperative for everyone to know.
Wonderful. Well, thank you again. Really appreciate your time today.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.